Good afternoon, ladies and gentlemen. This is my first time being in Vietnam, and I'm very happy to be here. I would like to thank the organizing committee for inviting me here. It's really my great honor. So in the next 25 minutes, we will discuss the imaging of small bowel neoplasm in the case-based fashion. So the small bowel neoplasms Okay. Actually, it's account only about 3% of all gastrointestinal tumors. It's rare. And for the evaluation of the small bowel neoplasms, CT enterography and MR enterography are the optimal imaging studies. They use negative oral contrast for bowel distension. And then we use IV contrast enhancement. So we can have the distended small bowel lumen, and the small bowel lesions can be seen more clearly. However, in the real world practice, often we see, we do not know that the patient have a small bowel tumor. The patients may present with abdominal pain or small bowel obstruction. And so often we see the small bowel tumors on ordinary CTs too. Let's start with the first case. It's 69-year-old woman. And she had a bladder cancer and it's now under regular follow-up. So she did not have any symptoms. And we can see there is an abnormal bowel loop at the left lower abdomen. And there is target-like appearance and a well-defined low-density lesion. So what is your diagnosis? So who will vote for 1, into succession? Or 2, duplication cyst? Or 3, lipoma? Or 4, gastrointestinal tumor? Which one will you choose? Okay, actually this is both. We have an into succession and we have a leading point as a lipoma. This is a fat containing lesions causing the into succession. So lipomas are the benign tumors and without malignant potential. It will arise in the submucosa composed of mature adipose tissues. Most of them are asymptomatic. It is important because it's the most common benign lesion to cause into succession in adults. On images, it will appear as a smooth mass with fat density. On CT, it will have a very low density, about -40 to -120 Hounsfield unit. And on MRI, it would have the similar signal intensity to the macroscopic fat. So in this example, we see a nodule inside the duodenum. On this T1 weighted image, we see the same signal as the visceral fat. And on fat-suppressed T1 images, these fat-containing lesion will have a suppressed signal. However, on the outer face images, the macroscopic fat will not have a signal drop. Okay, here is the second case. 17-year-old girl with oral pigmentations. And this is an MR enterography. On T2 weighted images, we see many intraluminal filling defects. And after contrast enhancement, these lesions shows good enhancement. So what is your diagnosis in this patient with the oral pigmentation? So who will vote for 1, familial adenomatous polyposis, or 2, Peutz-Jeghers syndrome, or 3, leiomyoma, or 4, metastasis? Okay, this one is Peutz-Jeghers syndrome. So Peutz-Jeghers syndrome is an autosomal dominant genetic disorder. It has characterized as the mucocutaneous melanin pigmentations. So often the patients will have a blackish pigmentations on the lips or the oral cavity, it has an increased risk of intestinal adenocarcinoma and non-gastrointestinal tumors. The patients will have multiple hamartomatous polyps in the gastrointestinal tract. These are composed of smooth muscles and covered by normal mucosa. It's most often seen in the jejunum, and then ileum, and then duodenum. It will look like the smooth enhancing intraluminal mass. It may cause intussusception. So these patients need to have a regular small bowel surveillance to detect large polyps, which is more than 15 millimeters, and these needs it to be removed because it may cause complications such as obstruction and intussusception. And MR angiography is a good tool to do the follow-up because it does not have radiation. It has an excellent concordance between MRE and enteroscopy for detection of large polyps. And also compared with capsule endoscopy, the MRE is less prone to miss large polyps. So it's actually a very good tool. Okay, let's move on to the third case. It's a 76-year-old woman who had a history of familial adenomatous polyposis. So she had already received a total colectomy and had an ileostomy. And now we can see that there is lobulated mass at the third portion of duodenum, causing the duodenal obstruction with dilated duodenum and stomach. So what is the duodenal region? How about one, adenoma or adenocarcinoma, lymphoma, or gastrointestinal tumor? Okay, so this one in a patient with familial adenomatous polyposis, it's adenoma. So adenomas are benign polyps arising from glandular epithelium. It's most commonly seen in the duodenum, and it's had a predilection for the ampulla of Vata. So it often occurs at the periampullary region. Usually will be solitary, less than 2 centimeters, and asymptomatic. And however, it could be multiple in the polyposis syndromes. It would appear as a smoothly outlined intraluminal lesion, and is most often sessile, which is broad-based without a stalk. It has a risk of malignant transformation. And in this familial adenomatous polyposis, this is autosomal dominant genetic disorder. So these patients will have innumerable colonic adenomatous polyps in a very young age, so multiple tumors in the colon, and it has a high risk for colonic and extracolonic tumors. And these polyps may go malignant transformation. So prophylactic total colectomy is suggested at a very early ages. And in addition to the colon polyps, over 80% of patients will develop duodenal adenomas, such as in our case, and it can also undergo malignant transformation to become the periampullary cancer. It is the second most frequent site of cancer outside of the colon in these patients. Okay, now this is the fourth case. The 69-year-old man with abdominal pain. So now we see there is dilated jejunal loops at the left side of the abdomen. And now we see that here is the narrowing part causing the obstruction with mild wall thickening and increased enhancement. And looking carefully, there is some overhanging edges here. So what is your diagnosis in this obstructive region? So who will vote for 1, Crohn's disease, or 2, lymphoma, or 3, neuroendocrine tumor, or 4, adenocarcinoma? Okay, so this one is adenocarcinoma. The patient has received surgery and the diagnosis was confirmed. So adenocarcinoma is actually the most common primary malignant small bowel tumor. It arises from the glandular epithelium, most commonly seen at the proximal small bowel, the proximal jejunum or duodenum. And on image, it will appear as an enhancing soft tissue mass. And often it's a very short segmental, circumferential, or eccentric luminal narrowing. And typically will have an overhanging edge, meaning that this edge is protruding. And most often it will cause obstruction. So if you see a lesion with obstruction, then it's adenoma. Adenocarcinoma should be considered. Okay, next. This is the next case. 76-year-old woman with poor appetite and weight loss. She came to our hospital and this CT was performed. So first we see many tumors in both hepatic lobes. On arterial phase, the tumor shows peripheral rim-like enhancement. It's a hypervascular tumor. And on venous phase, it shows hypoenhancement. And there are mild ascites and also many tumors on the peritoneum. So there is peritoneal metastasis. Also looking carefully, we see that there is a short segmental wall thickening of the ileum at the right lower abdomen. And also many enlarged lymph nodes, mesenteric lymph nodes at the right lower abdomen. So what is your diagnosis? So who will vote for lymphoma or neuroendocrine carcinoma or adenocarcinoma or for metastasis? Okay, so the patient has received CT-guided biopsy for the liver tumors, and it turns out to be a neuroendocrine carcinoma from the GI tract. So neuroendocrine neoplasms, they are classified based on the differentiation of the tumor cells. If it's well differentiated, then it's called a neuroendocrine tumor. And it's poorly differentiated, then it's a neuroendocrine carcinoma. And the primary lesion on the small bowel is most commonly seen at the distal ileum. The primary lesion is usually very small and often not visible on CT and MRI. But if it is visible, they will have a very strong arterial enhancement. It's a hypervascular tumor. And it often will have metastatic diseases to the mesentery, and it's more easily identified on the images. And we will have a desmoplastic reaction causing fibrosis, so the mass will appear spiculated, and it can typically contain calcifications. And then here is the next case. 53-year-old woman with a palpable abdominal mass, and she received this CT scan. So this is the pre-contrast image, and this is the post-contrast venous phase image. And the tumor is very large and with hypoenhancement. And here we can see that the large mass is connecting to small intestine. This one. This is a jejunal loop. Okay. So a very large tumor at the lower abdomen, growing outside, and this does not cause intestinal obstruction. So what is your diagnosis? Okay, so actually first she came to the gynecologic department and they thought that there was a ovarian cancer, but actually this comes from the jejunum. So the patients went surgery and the diagnosis was confirmed. So these are the resected jejunal loop, and here is the large tumor growing exophytically. So gastrointestinal stromal tumors, it is the most common mesenchymal neoplasm of the GI tract. they are most commonly seen in the stomach, but also it's can arises in the small bowel, about 40%. It's more often seen in the duodenum or jejunum. So on image, we can see that the tumor will grow exophytically outside from the lumen, and it can grow very large. And when it becomes larger, will have heterogeneous enhancement and may have necrosis, ulceration, cavitation, or hemorrhage. It will become very heterogeneous. And very importantly, that the lymphadenopathy is very rare. So if we see lymphadenopathy, then gastrointestinal tumor is less likely. So here's the next case. 62-year-old man with abdominal pain. So on this CT, we see that there is a mass at the right abdomen involving the jejunum, and with prominent wall thickening and relatively homogeneous enhancement, and the lumen is dilated without obstruction, and also very there are much enlarged lymph nodes on the mesentery. So what is your diagnosis? Okay, so this one actually is a lymphoma. This mass with a lot of lymphadenopathy. So lymphomas involving the small bowel, it can be the primary site or as a part of a widespread systemic disease. Most frequently will arise in the ileum. And there are many forms of the image appearance. The most characteristic form is the pseudoaneurysmal form. It's a mass-like wall thickening with preservation or dilatation of the lumen. So that's why it's called the pseudoaneurysmal form. And it will not cause obstruction. The lumen is dilated. So as you see in this one. And other forms include polypoid or endoexoenteric. This one means that there is a large mass connecting with the small bowel and have a cavitation that can connects with the intestinal lumen. This is called the endoexoenteric type. And other type includes stenosine and a mesenteric type. So there are some image findings that will suggest lymphoma. It will have a very homogeneous wall thickening and enhancement. It may have a coexistent lymphadenopathy. So this can help to differentiate between the lymphoma and the gastrointestinal stromal tumors. Okay, here is the last case. We have a 57-year-old woman. She had ovarian cancer and received operation 2 years ago. Now presented with nausea and vomiting. So on this plain film, this radiograph, we see the very dilated small intestinal loops. And so small bowel obstruction is suggested. CT was performed. So we see the these very dilated small bowels. And here there is a soft tissue in the pelvic cavity causing the bowel obstruction. And there is adjacent peritoneal nodule. Okay, so what is your diagnosis? So it's a post-operative patient. So will it be adhesion or lymphoma or adenocarcinoma or metastasis? The patient has received operation and it's turned out to be the recurrent ovarian cancers with metastasis involving the small bowel. So metastasis to the small bowel can go from hematogenous spread or direct invasion. And the ones with hematogenous spread includes are more commonly from the lung cancer, breast cancer, and melanoma. And if it's direct invasion, it's most commonly from ovarian cancer and colon cancers. And it can appear as a single or multiple polypoid intraluminal lesions or focal wall thickening. Usually, often causes luminal narrowing, and we may see evidence of other metastatic diseases elsewhere in the abdomen or pelvis. So this case is metastasis to the small bowel, and also we see the lymphadenopathies. And here is disseminated peritoneal metastasis involving the small bowel. So here is the summary of the common malignant small bowel tumors. For the adenocarcinomas, they arises in the proximal jejunum or duodenum. It appears as a short segmental luminal narrowing, and typically will have an overhanging edge, and it often causes intestinal obstruction. And for neuroendocrine neoplasm, it's usually seen at the distal ileum. And the primary tumor usually is very small and will be, it is a hypervascular tumor, had a good enhancement. And when there is mesenteric metastasis, it's a spiculated mass. And if it has a liver metastasis, it appears a hypervascular tumor. And the gastrointestinal stromal tumors often arise from the duodenum or jejunum. It will have an exophytic growth, and when it's large, will become heterogeneous, contains necrosis, ulcerations, and cavitations. And the lymphadenopathy is rare. And for the lymphoma, it's usually seen in the ileum, will have prominent wall thickening and homogeneous enhancement. And it's usually do not cause obstruction and may have some coexistent lymphadenopathy. Thank you for your attention.